So our first speaker is Dr. Tim Morgan, who's going to be speaking on alcohol-associated hepatitis, and he's really, I think, a world authority on ALCAP, very well NIH funded, involved with, over the years, many studies on ALCAP. So without further ado.
Thanks for the invitation to present on this very interesting disease that I've kind of been interested in for, oh gosh, more than 30 years, ever since I was a fellow at USC. And thanks for the invitation, and welcome everybody for a beautiful location and a wonderful meeting. So do I have control of this? Yeah, here we go. Okay, so it's changed its name. It's now alcohol-associated hepatitis or alcohol-related hepatitis. I'm just going to call it alcoholic hepatitis since that's what I'm used to, and I think most people are used to. I don't have any conflicts of interest. These opinions are my own and not from the Department of Veterans Affairs, who I work for. And I will discuss non-FDA indications because there are no FDA-approved medications for this disorder. I sent around an email to gastroenterology fellows, former fellows, and said, what do you want to know about if we're talking about alcoholic hepatitis? And they gave me this list of items. And interestingly enough, everybody wanted to know about the diagnosis of alcoholic hepatitis. So I'm going to start to some extent there. So when I think of the alcoholic hepatitis, it's a combination of two things. It's a combination of a chronic liver disease. Most of these people, well, all of these people have been drinking for a long time. Most of them have cirrhosis underneath it. And on top of that, there's something acute happening. And those two together make alcoholic hepatitis. And from the chronic disease, you have a history of alcohol use. You can have decompensations in the past. And you have some mild lab test abnormalities, frequently, but not always. They can have jaundice and elevated ASTs, mildly elevated white count. Usually it's completely normal, often lower than normal. But the acute component of this, again, is heavy alcohol use. And in a severe case, SEERS criteria, one or two of them, fever, tachycardia, elevated white count. But the jaundice is the very classic, you almost have to have jaundice to have severe alcoholic hepatitis. And typically the white count is elevated, although not always, but in a classic case it is. And again, they can have the same infections in AKI. And the problem is that the chronic part does not respond to steroids, whereas the acute part may respond to steroids. So you want to make sure that you're dealing really with the acute part. So about 5 years ago, 6 years ago, the NIH had a meeting where they decided they would write the criteria for the diagnosis of alcoholic hepatitis. And this is what they came up with. Now, I was a co-author on this and part of the group. I have to tell you that I find this to be a less than ideal I think you have to have all of these criteria, but we'll go into them. Look, you have to have heavy drinking. And what's that mean? 40 grams for women, 60 grams for men. That would be 4 or 5 drinks a day for men. Typically, these men are drinking 10 drinks a day or more. So it's really pretty heavy drinking. Now, the onset of jaundice is very critical, and usually recent onset of jaundice. Here it says bilirubin over 3, but if you've really dealt with severe alcoholic hepatitis, you're dealing with a bilirubin over 10, bilirubin over 15. So a bilirubin over 3 is what I call mild alcoholic hepatitis. You do a biopsy, you may find it, but you don't worry too much about it. AST is usually elevated, but less, well, almost essentially has to be elevated, but usually not severely elevated, so it's less than 400. ALT is less, the ratio is 2 to 1. And we talked about SEERS, and if you're confused, you can do a liver biopsy. But the heavy alcohol use, recent onset of jaundice, and jaundice are absolutely critical. Because we don't do liver biopsies in America, it would be nice to have a blood test for this. There isn't any. but there may be one in the future. And this was a study that looked at extracellular vesicles that are released from hepatocytes and circulate in the blood. And on the left-hand panel and the right in the red, you can see on average, the extracellular vesicles were increased in people with alcoholic hepatitis with a pretty good area under the ROC curve, but it's not yet available, but it might be available in the future. So what's my general approach? If the MADRS discriminant function is over 32, these people are sick. And I think they ought to be hospitalized. Infections, we'll talk about several times. We'll talk about it here. Look for infections. About 25% of the people have infections on admission to the hospital, most commonly SVP, but it could be anywhere. So that means culture, ascites, urine, blood, chest x-ray, diarrhea, do C. diff. I strongly recommend, and I'm sure everybody does, some sort of imaging of the abdomen, just to make sure there's nothing unexpected in there. You typically have ascites, but you don't want to see masses in the liver, a biliary tract obstruction or something else. What's the baseline treatment of this? It's basically nutrition. All of these people, essentially all of these people with severe alcoholic hepatitis have protein-calorie malnutrition. And diet is essential for their survival. Give them calories, and you can see there for an 80-kilogram person, it's 2,600 to 3,000 calories. Protein, plenty of protein. Don't worry if they have hepatic encephalopathy. You can treat that in other ways, and they need the protein. Sodium restriction, ideally 4 or 5 meals a day, including a kind of an evening meal, and multivitamins and zinc also. And on the right-hand side, you can see that the amount of food they take is correlated with survival. In the upper panel, the bars represent mortality, and the purple bar on the right are people that ate less than 1,000 calories. And as you eat more calories, your mortality goes down. And the lower one, you can see if you ate more food, you had a better survival. So when you go to see one of these people in the hospital, look at their plate and see what they're eating. If they're not eating, I kind of use that as a bad sign that, you know, these people have a poor prognosis, and you really have to talk with them about food. How do you assess severity? Well, there's multiple different scoring systems shown on the left. The oldest is MADRS discriminant function, and everybody's been using MELD for a long time. It uses it for many different liver diseases. And then there's ABIC and the Glasgow Alcoholic Hepatitis Scale. And you can see most of them use similar criteria, and then they added on other criteria for some of the lower ones. Liyun model is not baseline. It's after day 7 to assess response to steroids, but I think it's quite good in predicting survival. So now I'm going to show you how these different scores kind of compare to each other in predicting 90-day survival. That's that graph. And you can see the different lines pretty much are similar. And in the table at the bottom, under the area under the curve, you can see that they're 0.77 for MELD, 0.77 for MELD sodium, 0.71 for MADRS discriminant function, and then 0.76 and 0.74 for the other two. So they're all pretty good at predicting 90-day mortality. So I tend to stick with the MADRS discriminant function as my kind of go-to, and MELD. I don't use the other two, but if you want to, you can. If you want a little bit more accurate 2-month or 6-month prediction of survival, then you can use the MELD score on admission and the Liyun score at day 7. And you get this graph here, a Liyun model or Liyun score at the bottom and MELD on admission. And it gives you an estimate of 2-month and 6-month mortality. What's the treatment? Well, I think nowadays it's basically corticosteroids. All these are equivalent: prednisone, prednisolone, methylprednisolone. Prednisone is the old one. I think it's fully acceptable. People changed to prednisolone because prednisone has to be metabolized to prednisolone in the liver to become active. And there was concern that it may not be metabolized in a sick liver. It's much more expensive than prednisone. Prednisone is pennies a day. Prednisolone is, I don't know how much, it's many dollars a day. and methylprednisolone is an alternative. And it's 28 days based on a study that was done in the 70s. And there's an interesting history to that, but nobody's ever tested longer or shorter. So it's 1 month. Now, why do we use prednisone or prednisolone? It's based on a meta-analysis of multiple different trials published here. This is the 1 month mortality, survival, but 1 month mortality of about 20% with prednisone and about 35% with placebo. A very highly significant difference with about a 40% decline in mortality with steroid treatment. And this is people, there are issues with steroids that I'll get to on the next slide, but this is if you're going to use something, I think prednisone or prednisolone or methylprednisolone is the way to go. Now, this is from the STOPPA trial, which was a large UK trial of about 800 people, comparing 4 different treatments: placebo, or prednisone alone, or pentoxifylline alone, or prednisone and pentoxifylline. And they followed these people for a year. And so you got 4 curves there. And because we've been looking at this disease at survival at 28 days, that was their outcome. And you can see the line there at 28 days, but you can see that there's a lot of life left after 28 days, like 11 more months. And at 28 days, the people that got prednisone did slightly better than the people that got placebo. And the people that got prednisone is in the red line. And at 28 days, the red line is up at the top, meaning less mortality. But let's go out to 180 days, the middle of the graph, or even if you go out to 90 days, or you go out to 365 days, the red line is the lowest. So if you got prednisone alone, you had the lowest survival after 30 days, especially 90 days, 180 days, and 365 days. So that's why a fair number of hepatologists are not very excited about prednisone as a treatment. I'm somewhat in that camp also. And unfortunately, if you really look closely, the people that are doing the best at 180 days, that's the placebo patients. Okay, now if you're going to use steroids, I strongly recommend using the Lille score after 7 days of prednisone to determine whether this person is responding to the steroids or not. It's online at many different calculators. It's also online at lillemodel.com. And it has age, creatinine, bilirubin, protime, albumin at day 0, and very importantly, the change in bilirubin at day 7. So you're looking, the previous version of this just looked at an improvement in bilirubin at day 7 by, I think, 20%. But it turns out that that's very important in determining survival. There's a Lille model off on the right. You can do it at day 4 and get a pretty good discrimination between responders and non-responders. I still tend to use day 7. Infections, I don't worry about infections too much before starting steroids based on this study. And these are the survival curves at 60 days among people that had infections prior to starting the steroids, got their infections treated for a few days, got it under control, and then started steroids versus the people that were not infected at baseline. And you can see the survival is about the same. So I don't worry too much about infections prior to starting steroids, provided you can treat the infection. But infections after you start steroids are bad news. And they happen with increased frequency in people taking steroids. So you got to look for infections after you start steroids, and especially in the nil non-responders, because it's a marker of decreased survival. Now let's look to the future a little bit. This was presented at AASLD. I found it, quite interesting. This is a cholesterol derivative given IV at day 1 and again at day 4. So 2 infusions very early on. That's it, done. And there was a suggestion towards improved survival in the lower dose. I'm not quite sure why the higher dose didn't work, but I think that this is a drug worth studying. It would make life a lot easier. Another you should know about kind of thing from San Diego, Bert Schnabel studied stool samples from alcoholic hepatitis patients and found that patients who had cytolysin positive Enterococcus faecalis had a decreased survival, and the people that had cytolysin negative did not have a decrease in survival. Their survival was pretty good. So this is a toxin that is produced by Enterococcus, but not all of them. Shown on the left-hand side, you can see about 25% of people with alcoholic hepatitis have cytolysin positive Enterococcus. We don't have any way to really test this or treat this, but I think that there are people interested in phage therapy that attacks specific bacteria, and there might be a specific one. Now, what about you get them out of the hospital or you get them in the hospital? This slide is one of these ones that I think is actually very important, and I didn't pay enough attention to until much more recently. And that is that, and we all know this, but I focus on liver disease, not on the substance use disorder problem. And so they come to me in the hospital and I try to maybe give them steroids or not, but manage their ascites and their encephalopathy and all that other stuff. And then you get them out of the hospital. But the survival out of the hospital really depends on their alcohol use. And I think that you have to do your best to get these people to an alcohol treatment program. Again, this is from the STAPA study, and it shows 4 categories of patients at day 90. One group was abstinent. One group was continuing to drink at the same level. One group was drinking less than on admission, but above the safety limit. Safety limits in England is 1 drink a day for women, 2 drinks a day for men. And then the bottom group is reduced to drinking, but below these limits. So in theory, not very much. And the odds ratio in dark black shows you that you have an increased mortality no matter what you're drinking compared to people that are abstinent. So abstinence is critical for these people's long-term survival. Well, then we touch on liver transplantation. This is from Philippe Mathurin, the people that created the Lille model. And Philippe's a friend of mine. And I remember when he told me that he was doing liver transplantation someplace, I don't know, 2005, 2006, 2007. And I thought that was a radical idea. Like, no, you can't do that. But they did it. And then this was published in the New England Journal in 2011. And it shows the 2-year survival in the people with acute alcoholic hepatitis not responding to steroids. These are very sick people that got a liver transplant, survival shown in the top line, compared to matched controls from their database that did not get a liver transplant. You can see the survival is terrible. And that kind of opened the door, and people began to think more and more about liver transplantation for severe alcoholic hepatitis. And the French group then did a prospective study comparing early liver transplantation, within a month or so after admission for alcoholic hepatitis in people that failed to respond to steroids, versus the standard, which was, wait 6 months, abstinence for 6 months. And this is their prospective study. It couldn't be randomized. You can't randomize this. But you can see on the left-hand side that the survival curves were exactly the same over 2 years. And there were 68 people in the, urgent, the immediate transplant group, and about 100 people in the standard transplant group. But the concern is shown on the right, which is alcohol use. And shown in blue is the relapse rate with early liver transplantation versus the alcohol relapse rate with standard liver transplantation. Now, the thing is, I have to be careful because I think this is being recorded. Honestly, if you get a liver transplant, and you drink one drink this week and one drink next week and another drink the week after that, to be honest, it probably isn't going to hurt your liver. But if you drink every day, especially if you drink heavily, it's going to catch up with you, my opinion. And so it's not just that there's more alcohol use in the people that got early liver transplantation. If you look in the box down at the bottom, it's the heavy alcohol use. And it was quite considerably more frequent among the people with early liver transplantation. So, you know, Jeff sees people with liver transplant, and I'm afraid that over time, this may add up. And although there's no patient difference survival at 2 years, look at 5 years or longer. And this is several different studies that were reviewed here this year, where they looked at alcohol use after early liver transplantation for alcoholic hepatitis. Look more at the green bars because that's harmful alcohol use. And you can see it's 20%, 10%, 15%, 11%, 12%. So it's probably somewhere between 10 and 15%, which I don't know. It's a judgment call, whether you want to do transplantation and have 15% of your people go back to heavy alcohol use. Well, how can you choose people better? And these are some of the different scoring systems or approaches to choosing people that are more likely to relapse after alcohol use. And, you know, these are probably more, we as referring physicians don't use them as much as the liver transplant center would use them. So I have my shorthand view of this, which is how many times have you relapsed? If you've failed 2 treatment times, you've come into the hospital with an alcohol problem and then you went home and you kept drinking and you came back with another alcohol problem and you went home and you started drinking again, that's 2 failures. That's pretty negative in all these scoring systems. And then it's really how much are you drinking? You know, is it heavy alcohol use, which most of these people, it is heavy alcohol use. So that's my just kind of, you know, offhand. When you go to a transplant center, you'll get a much more detailed assessment of likelihood. So what do we want to do when we summarize here? Nutrition is important. All these people have protein calorie malnutrition. You can use discriminant function or MELD over 20 to assess whether you want to give them steroids. Steroids probably decrease mortality by about 1/3 at 1 month, but there's no known or demonstrated survival benefit at 6 months. I stopped the steroids based on a Lille score at day 7. Look for infections before you start the steroids, during the steroids, and certainly after the steroids. If anything, they start to go down the hill. It's culture time. Abstinence is essential. Refer these people to substance use treatment programs. Talk with them about it. Usually the typical thing is they say they'll never drink again. They say they don't need to see a substance use. They got it under control. And you know what? They won't drink for 3 months. They may not drink for 6 months, but there's a high recidivism rate and it will affect their survival. And you can consider liver transplantation if there's essentially no prior or minimal prior alcohol-related problems and they have good family insight. Thank you.
Great. That was great. Thanks so much, Tim. So our next speaker is Dr. Liyun Yuan, who is my colleague at USC. She's assistant professor of clinical medicine, and she has a strong clinical and research interest in what we used to call NASH, and I still see it's on the program as NASH, but MASH. So anyway, thank you.
Thanks for introduction, Jeff.
Just changing the slide.
Thanks to SCSG committee for invitation. It's my honor to give presentation of MASH abstract update from AASLD. Here is my disclosure. No more NAFLD, it's called MASLD. And this is a new term. Additionally, there's a new term of MET-LD. This is the group of patients with mild and moderate drinking history. So this abstract show there is going to be increasing burden, economic burden, social burden on mild in the United States. It forecasts the population will grow to 40 million by 2044, 2.5 million patients with cirrhosis. And the estimated cost will increase to 16.8 billion. How we can reduce the cost? Screening, awareness, and education, starting from primary care clinic. AASLD guideline in 2023 laid out this algorithm using FIB-4 score algorithm as screening tools. Patients with FIB-4 score more than 2.67 should be considered referred for GI liver clinic. And the indeterminate FIB-4 score from 1.3 to 2.67 should consider second testing such as FibroScan and alpha test. So this abstract investigates the cost-effective in the patient with FIB-4 score 1.3 to 2.67 is at the additional testing FibroScan and alpha score is going to be cost-effective. Yes, it is. It shows with the combination of two, when we're dealing with the population, 25 to 40% in this indeterminate range account for mild population. And it can reduce the cost $1,000 per patient overall. So how are we doing so far in our primary care clinic? This abstract actually show from Mount Sinai when they investigate in the endocrine and diabetes population, which is the population at high risk for mild. They found very few patients were referred to GI hepatology, and only 9% patient with FIB-4 score more than 3.25, which indicate patient may have early cirrhosis, has been referred to hepatology. So over 91% cirrhotic patient underdiagnosed. The problem is significant. How we can improve and in the primary care clinic from this abstract from UCSF and Kaiser Permanente, they simply just implicate 18 months EMR reminder, notification, education. And you calculate FIB-4 score and send notification to reminder for PCP. With this simple, very simple 18-month intervention, it significantly improves PCP awareness and the understanding of FIB-4 score component. And they are more likely use FIB-4 score for referral, patient care, management of patient with mild. So this also published in GOT in 2023, the same idea in they use EMR reminder and they have control and intervention. With the intervention, they can improve, 30% compliance rate. I know many clinical investigators like me are very frustrated with MASH clinical trial because the screening failure rate is up to 85%. And Stephen Harrison et al. Look into 8 therapeutic non-cirrhotic trials, include 6,000 patients, over 2,000 MRI, FibroScan liver biopsy data, and over 5,000 lab data. They look into the patient with biopsy-proven severe NASH and advanced fibrosis compared biopsy-failed patient. They found the patient with age more than 50, in FIB-4 score, FAST score, AASLD, and on the top, diabetic, pre-diabetic status are significant. So they conclude if we try to improve our screening failure for clinical trial, which is we try to identify patients with MASH, advanced fibrosis, and we should consider such group of patients, middle-aged patient with multiple comorbidity, particularly type 2 diabetes. And if patient A1C is less than 6.5, use FAST score more than 0.67. And if patient A1C more than 6.5 and use FAST score more than 0.5, that will increase our screening success. Familial risk has been very well recognized. Patient with MASLD, particularly advanced fibrosis, their first degree relatives had higher risk for advanced fibrosis as well. So this abstract looked into familial score, and they found first degree relatives have almost 15% prevalence of advanced fibrosis. So they lay out in this familial risk score include age, type 2 diabetes, obesity, and family history. Patient with score more than 4, they recommend further testing, including fibroscan such as MRE, and look into high-risk NASH with advanced fibrosis. Now look into non-invasive testing and artificial intelligence. We know biopsy is impractical for all patients. How we can utilize non-invasive testing to screen in patients with advanced fibrosis, both for clinical trial and clinical management. Dr. Matthew Norton, they compare 4 non-invasive testing. This is a combination with imaging and lab testing, FAST score, MAS score, MED54 score, and CT1, compared with liver biopsy among 170 patients. The data show MAS and FAST score has demonstrated superior performance in the identification of at-risk for NASH. So this could be very good score in our clinical, and we're starting slowly coordinate FAST score into our FibroScan. Machine learning, when dealing with this massive population, massive data, machine learning undoubtedly is very helpful. So this abstract present, they use machine learning, try to identify high-risk factor for particular for a FIB4 indeterminate range, which is huge population of the patient, and how we can reduce the cost. So they use machine learning and algorithm generate this model to which feature with age, AST, alkaline phosphatase, platelet count, type 2 diabetes, hypertension. And this they call ELM, can coordinate with FIB4 and reduce indeterminate range population and decrease need for second-line testing. It's very readily available value and no cost. So I think this might be very good to implicate in MR system in the future. Excitement for pipeline of clinical trials. We have a lot of promising target, and so this retatrutide, we know semaglutide is a GLP-1 agonist. Tirzepatide is a GIP-GLP-1 agonist. Retatrutide is triagonist of GIP-GLP-1 glucagon receptors. These trials report in the AASLD show Reta has significant weight loss potential. The higher dose lead to 23 to 25% weight loss. With this higher dose, you can see the liver fat has significant reduction, over 70% liver fat reduction among the patient with high dose. Iconsapetide, this is a double-blind placebo-controlled phase 2b trial, and this is fatty acid receptor 1 for agonist, and they also have posture agonist toward PPAR alpha receptor. It's targeting at fatty acid metabolism and insulin resistance. And the treatment with high dose show 25% with histology response, and particularly in type 2 diabetes patient, 35% with histology response. FGF19 analog adafermin and in well-compensated cirrhotic, the trial look into regression of fibrosis. So with the treatment response histology-wise, there's no regression of fibrosis significance, but they use non-invasive testing alpha score. It shows significant in alpha score reduction and dose-dependent improvement in process 3 and AASLD. Pegozafermin and it's also a cirrhotic trial, and it's FGF21 analog pegnated, has prolonged pharmacokinetics and weekly injection or every 2-week injection. This trial data has been published in New England Journal of Medicine, showed this, the improvement of resolution of NASH. From that, they reclassified 14 patients from stage 2 to 3 fibrosis to stage 4 fibrosis. Relook into this patient, they found significant regression of fibrosis. They also using non-invasive testing showed a significant improvement. Of course, this need to be validated in separate dedicated study with patients with well-compensated cirrhosis. Resmetirom from Madrigal is an oral liver-directed thyroid hormone beta selective agonist. This just published in Nature of Medicine. It showed significant improvement in NASH and regression of fibrosis. The data show 50% with patient with higher dose have NASH resolution or fibrosis improvement. In this abstract, they quantitate the non-invasive testing MRI PDFF reduction, more than 30% reduction in coordinate of biopsy histology improvement. They're also using non-invasive markers, sex hormone binding globulin. It also, the increase, 120% increase is associated with biopsy response. So it's very exciting, but what has been in our pocket? What's in our pocket? Statin. Statin has been very well studied to improve all aspects of mast cell outcome. This particular study looked into the incidence of cirrhosis. They used VA population, look into 2007 to 2009. And over 10 years follow-up, and the outcome they look into is with the diagnosis of mast cell 10 years ago, the incidence of cirrhosis. They found a patient on statin use has a significant reduction of incidence of cirrhosis. The RR ratio with all adjusted models, the RR ratio is 0.74. And both men and women above age of 50 on statin use has reduction of significant incidence of cirrhosis. Daily aspirin, this is randomized clinical trial with aspirin, which is brilliant. I think it's very brilliant. And 40 patients on baby aspirin treatment and 40 on placebo, 6 months follow-up. And they use MR spectroscopy quantitative liver fat as endpoint assessment. And the patient on aspirin treatment daily showed a significant reduce of liver fat content compared to placebo. Vitamin E, lower dose, 300 milligram for 50 units. This data from Chinese NAFLD Clinical Research Network. The randomized patient with treatment group and placebo use liver biopsy confirmed MASH, and also the outcome was assessed with liver biopsy after 96-week treatment. It showed 43% patient response compared placebo 17%. Now come to my favorite. I want to share several my favorite presentation abstract. Bariatric database. And this is a French cohort and very exciting data. I think they have this bariatric cohort, and the patient had biopsy prior or at time of bariatric surgery, and 1 year and 5 year post surgery biopsy. And this is 15-year follow-up, and they look into MASH resolution without worsening fibrosis, persistent MASH or worsening fibrosis. What they look at is overall survival of the patient of 15 years. And they found the patient with MASH resolution or with MASH resolution without worsening fibrosis has very favorable survival comparable to the patient without MASH. Those patients with persistent MASH and or worsening fibrosis has decreased survival. They conclude resolution of MASH with no worsening of fibrosis is a reliable surrogate marker endpoint for in the content of bariatric surgery. It might be in the content of clinical trials, our daily treatment of a patient, how we assess patient, because fibrosis does need time to resolve. And how about lean MASH? And so this study look into patient with lean MASH cirrhosis, how's their outcome and mortality. The patient with, they look into VA cohort and how they define lean MASH, and is the lean status BMI less than 25, and for Asians less than 23, 12 months prior to cirrhosis diagnosis. The outcome they're looking for is liver-related outcome, cardiovascular-related outcome, and non-liver, non-cardiovascular-related outcome. They found patients with lean MASH cirrhosis compare non-lean MASH cirrhosis. The liver mortality and cardiovascular mortality is almost equivalent, but non-liver and non-cardiovascular mortality are higher in lean MASH population, cirrhotic population, which is very shocking. I think this is the patient population we need to pay attention to when you look into and follow along closely. Another abstract I like very much, and then look into the interaction of genetic factor and the environment. We know PNPLA3 polymorphism is a major genetic determinant for chronic liver disease and complications. So can environmental and dietary attenuate or exacerbate their effect? So this study look into the general population from Nutrition Health Survey, and they over 7,000 participants have genetic data. So they look into this high risk G allele compared to no risk C allele, and they found the light to moderate drinking and BMI more than 30 and high consumption of high fat, high cholesterol diet has increased risk for chronic liver disease. And they also have a joint deteriorated effect. Those in tea consumption, coffee consumption more than 3 cups a day, and also consumption of monounsaturated fatty acids such as olive oil and sesame oil and avocado or these goodies, and they have protective effect, and they also have joint protective effect. And this study from UK cohort, and I think it's brilliant and impressive. They have this amazing 500,000 participants, and the amazing thing is they have baseline assessment, and they have 24-hour, very, very detailed food recall. And they also have follow-up, and 50,000 participants have MRI data. Of course, this is massive data, and they use machine learning and the random forest classifier to find this strong association of steatosis and nutrient. So all these food record, they have this very detailed portion of nutrient. They found the manganese showed a strong association of fat reduction, and manganese also showed a strong association with decreased incidence of any type of chronic liver disease. What food rich in manganese? All these goodies, nuts, seeds, dark chocolate. Yay. All right. Yeah. All right. Thank you.
That was great. Thank you so much, Liyun. And now we can all eat chocolate, which is great. I think we're going to have a little bit of a change in the order, is my understanding. So our next speaker is going to be Dr. Richard Finn, who's from UCLA. He's professor of clinical medicine, and he has a very strong clinical research, laboratory research, and clinical interest in HCC, and especially trying to figure out how to target treatments for particular patients with particular tumor characteristics.
Thank you very much. I don't think there was a change as much as a typo in the printed version, but thank you very much for the invitation. I know there's a lot of strong liver cancer folks here in Southern California, and you rotate, and it's good to be back. And I'm always happy to interact with my hepatology colleagues. So I know this is an AASLD review meeting. There was some liver cancer stuff at AASLD, but there's also been a lot of liver cancer data at other meetings over the year. And I think it's important that we cover that and catch up with everything. And I don't know if it's just you, but from Southern California, coming from LA and coming here, it's hard to believe we all live in the same state. It's really so beautiful here. It is much different than Los Angeles. But the management of liver cancer is very dependent on a strong collaboration between oncology and hepatology. Outcomes for this disease are getting better, but outcomes are strongly dictated by their underlying liver function. This is the BCLC, which was updated in 2022. The AASLD updated their liver cancer guidance this year, but very much follows this as well. And as you know, staging in this disease is not just concentrating on the tumor. Other tumor types, gastric, colon, gallbladder, cholangio, TNM, tumor node metastases. But liver cancer takes a different approach, stage 0 ABCD, and looks at not only tumor characteristics, but also characteristics of their liver disease. Because you can have someone with a 2-centimeter tumor who's got a MELD of 35, they're not going to die of cancer, right? So the BCLC is based on the Child-Pugh score. It takes into account their performance status. And most of the patients we probably see are intermediate Barcelona B, who are fairly well compensated, but have multifocal liver cancer confined to the liver. They're generally asymptomatic. Backbone for these patients is local regional treatment, but it's been appreciated now, and I don't think I have a pointer, but it's appreciated now that there's some patients with intermediate disease who are probably better suited with medical treatment than local regional treatments. And that reflects the improvement in treatment available for these patients. At the same time, there's going to be stage migration. Increasingly, some patients with intermediate disease will be downstaged with local regional treatments and be candidates for transplant and curative approaches. But also, local regional treatment is not curative in and of itself. And these patients will become refractory and migrate to more advanced disease and require treatment with medical treatments. And it's important to keep in mind that their underlying liver function is important, and you have to stay engaged. If you send someone to interventional radiology, there will be a time for them to stop, because if patients decompensate, their benefit from medical treatment is going to be limited. And increasingly, as we see the survival for advanced liver cancer probably approaching 2 years, And when I started in this program a while ago, survival was 8 months. So we have come a long way, and we're going to continue to see improvements. But patients are starting to outlive their livers, to be honest. Patients with advanced liver cancer have their tumors controlled, but their tumors are getting worse. Their liver function's getting worse. And I circle here those patients who are candidates for medical treatment. The intermediates who have big diffuse tumors. The question when we treat a patient as internists is not, can we do it, but does it help? And sometimes our colleagues in interventional radiology, they concentrate, can I do it? At the same time, as I mentioned, those patients who will get local regional treatment might progress. And then there's a group of patients who present with vascular invasion, extrahepatic spread, and those patients just should get systemic treatment up front, the Barcelona stage C. Now, this is a summary of the positive phase 3 studies that have led to global approvals in liver cancer. And there's some important things to keep in mind. Clearly, they're all positive. The first was sharp compared to placebo. Survival was 10.7 months with a risk reduction of 31%, and hazard ratio of 0.69. And we did this without inducing objective responses. 2% objective response rate. In 2017, we saw the approval of lenvatinib based on non-inferiority to sorafenib, but survival had improved to 13.6 months with both drugs, roughly. It did, for the first time, we had a TKI that had a real objective response rate, 19%, and that's been confirmed in subsequent phase 3 studies. In 2020, we saw the approval of atezolizumab and bevacizumab, a big move forward for our patients. Updated data published last year shows the median survival in this population was 19.2 months and a significant risk reduction and a significant objective response rate. 30% of patients have their tumor shrink, and if you have a response, median response is well over a year and a half. And then last year, we saw data with Himalaya that led to the approval of a dual immunotherapy, dual checkpoints. Beat sorafenib with a hazard ratio of 0.78. Median survival in this population was 16 months, and objective response of 20%. And again, very durable. And we saw some updated data at AASLD on Himalaya, which I'll share with you. It's important to note the baseline populations here. VP4 invasion, so invasion in the main portal vein, probably one of the worst prognostic factors in liver cancer. Some studies include those patients, some do not. And, it's important to keep in mind that with IMbrave, we saw survival of 19 months, including patients who had this main portal vein invasion. For patients who progress, there's several drugs approved. Regorafenib, cabozantinib, ramucirumab, all approved based on positive phase 3 data after prior sorafenib. No drug has been studied formally in a phase 3 study after lenvatinib, let alone atezobev, let alone durvalumab and tremelimumab. And so what this means is that when we treat patients now who are getting frontline immunotherapy, we don't know the true impact of these drugs. But in general, in cancer medicine, when we make progress in frontline, we don't go ahead and repeat every phase 3 study that was done in the past. We've proven these drugs are anti-cancer drugs. These were all studied versus placebo. So, the bar was low, so to speak. But patients are cycling now through 2, 3, 4 lines of therapy. Pembrolizumab is still approved as a single agent in second line, but the population is shrinking because most patients will get immunotherapy frontline. And still, dual checkpoint and ipilimumab and nivolumab are approved as well. And again, most patients are getting frontline IO. But there is evolving data that for patients who just get a PD-1, a programmed death receptor 1 inhibitor, or PDL ligand inhibitor as single agents, that there is a role potentially for dual checkpoint inhibitor therapy in second line. So let's walk through some of the data. IMbrave study, you're familiar with it maybe by now. It was a global study comparing atezobev versus sorafenib in an open label study. And the primary endpoint was overall survival. That was met in the interim analysis with a hazard ratio of 0.58. That is better than how sorafenib did versus placebo. And this was the first time dual checkpoint inhibitor or any systemic treatment improved survival versus an active control of sorafenib. And objective responses were 30%. And we've seen complete responses, patients whose tumors completely disappear. And it's remarkable to see this. And IO has impacted virtually every malignancy we treat now. And if you respond, you do really well. We do not know who responds. There's no biomarker or clinical characteristics that tell us who really benefits. There's been consistent data that perhaps those patients who have inflamed tumors, a lot of T cell infiltrates in their tumors, decreased Tregs tend to do better, but there's no clinical test for that that's been validated or used in the clinic. And as you know, all the studies done in advanced liver cancer concentrate on patients who are Child-Pugh A, right? Why is that? Well, because the endpoints of these studies are to show an improvement in overall survival from anti-cancer treatment. And if someone's decompensated, you might have the best treatment for liver cancer, but you can't show it improves outcomes because they die of liver failure. But keep in mind, in practice, many of us will treat patients who are less compensated. And it's also important, and again, not so much for this audience as much as when I talk to my oncology colleagues, but there's a difference between a patient who's well compensated, develops cancer and decompensates, versus someone who's well compensated and develops a tumor, right? For that or the patient who's always been decompensated and develops a tumor. And let me just say that again. So someone who's got Child-Pugh C, waiting for a transplant, develops cancer, very different than someone who's well compensated and develops cancer and then decompensates. There's patients whose liver function is doing poorly because of their large tumor burden, and they need a response. And therefore, it makes sense to treat those patients if you can manage toxicity. And we've shown for patients who have an objective response, they do very well. You can see here in the blue line, patients who have an objective response, their survival curve is very favorable. Out over 2 years, we still hadn't reached the median survival. If you have stable disease, still your survival of 17 months is a big improvement. But a big unmet need is if you get immunotherapy and you progress very quickly, that's a bad prognosis patient. And we still don't know how to rescue those patients. Certainly, they'll cycle through all the drugs we have, but a big unmet need. And I commented about those patients with VP4, this so-called high-risk group. And if you look at this curve in high risk, certainly they do better with systemic treatment with atezobev. Hazard ratio is 0.62, but their survival is still far from optimal. And again, another unmet need for patients who have main portal vein invasion. They benefit, but their outcome is very poor. Now, safety is obviously something very relevant, and it's important, and all of you, I think, are aware that the use of immunotherapy carries the risk of autoimmune events, including autoimmune hepatitis. That's a rare event in general, to see severe autoimmune hepatitis. Certainly, we see AST and ALT elevations, but it's important for all of us to have this in our differential diagnosis as we treat patients. Here, seeing the most common adverse events with atezobev, that is dominated by hypertension, proteinuria, things associated with bevacizumab, an anti-VEGF antibody, just like we see with sorafenib, regorafenib, ramucirumab, cabozantinib, all these anti-VEGF drugs. But, you know, the one risk that we are seeing with bevacizumab is the risk of GI bleeding. And as you need to be aware, and patients who receive this regimen need to have an upper endoscopy within 6 months. That's how the study was conducted, and that's to minimize the risk of bleeding. So I I really plead with all of you, if your oncology colleague says this patient needs an EGD because they need to get started, don't tell them it's going to be in 6 weeks, right? You need to fit these patients in and get them done quickly so they can get started on their therapy. The other thing to keep in mind, is do we have markers for who's at high risk for bleeding? Certainly, main portal vein invasion is a high risk bleeder because they have significant portal hypertension. If I see a patient who has a platelet count over 100,000, has no bleeding history, I'm okay getting them started on their first dose and getting an EGD in the near future. This isn't heparin. It doesn't, you give it and they don't bleed. It's a biological event. So here you see all-cause bleeding events, higher than with sorafenib, but most of that is driven by epistaxis and hematuria, low-grade events. Grade 3 and 4 events, which are higher grade events, are fairly similar between both arms. But if we look at grade 5 events, there were 4 events that led to death with atezo-bev versus none with sorafenib. Now, that's still 1%. And again, all these patients had VP4 invasion. Big news this year, presented initially at AACR, but was also presented at AASLD and has since been published. For the first time, we saw a role for systemic treatment in earlier stage liver cancer. And IMbrave050 looked at patients who had curative resection or curative ablation and were high risk for recurrence. And as you know, recurrence in liver cancer is somewhat bimodal. There's patients who recur within a year or two, and we generally think those are patients who are recurring with the tumor that was treated or resected, but they still have a sick organ behind, and there's the risk of later recurrence because you left a cirrhotic liver or pre-malignant organ. So this study was a randomized study that gave patients a year of atezo-bev or just active surveillance, which was standard of care, right? There's no role for doing anything other than following these patients. And the primary endpoint was recurrence-free survival, how long it took them to recur after transplant. Now, there's several studies in this space. This is the first one to read out, but they all used a little definition of who's high risk, right? They didn't just take every patient who had a resection and randomize them. They took patients who had these characteristics for high risk: microvascular invasion, large tumor burdens, poor tumor differentiation. They did include some patients who had an ablation, which, single tumors 2 to 5 centimeters. I think we can argue, what's the real risk for recurrence of a 2.5 or 3 centimeter tumor treated with ablation, but this is what they did. Most of the patients who came on this study were treated with resection. This study was stopped at an interim analysis because the recurrence curves separated early and remained separated. And you can see here the hazard ratio of 0.72 indicates a 28% decrease in the risk of recurrence. The medians have not been reached. Still, you can see a lot of patients are censored. Will this treatment improve overall survival? We don't know yet, right? But I would argue, it's going to be very hard to tell because these patients recur, then they get multiple treatments, and you can't control what happens. So the decreased risk of recurrence is probably significant. There were really no new safety issues in this population. Obviously, if they had a resection, they're not so cirrhotic. And while we are still waiting for FDA approval for this indication, atezo-bev is approved in advanced disease, and I've had occasion to use this for patients who are resected and high risk, especially someone who were found to have microvascular invasion. We had a guy resected with a 14 centimeter tumor. These are patients who are at higher risk. And so this was what was presented at AASLD as well, trying to identify a group of patients who are higher risk for recurrence. And again, I think they just analyzed IMbrave050 data. This came from Taiwan. They did not have prospective data of their own, obviously, because this has not been used widely, and broke patients into 3 different groups. even within the IMbrave 050 study, and we're able to identify a group of patients in this model who actually get an even greater benefit with atezo-bev. I presented earlier this year a study looking at a new immunotherapy triplet. This was a phase 1 study. This was presented at the ASCO meeting. This was atezo-bev plus tiragolumab. This is a new antibody against a protein called TIGIT, which is another immune checkpoint involved in immune regulation and anti-tumor immunity. We looked at this triplet versus atezo-bev, and given a relatively small cohort, we had an objective response rate of 42% in this population. There was an atezo-bev arm here that only had an objective response rate of 11%, which I would argue was underperforming, but it was only 18 patients in that arm. But needless to say, this response rate of 42% is significant when we think historically this was 30% in other phase 3 studies. And progression-free survival with this triplet was 11 months. So this is the time patients start on treatment until they progress. And compared to the historical endpoint in IMbrave 150, which was 7 months, again, a potential signal that this triplet of 3 monoclonal antibodies might be important. And by adding this antibody, tiragolumab, the only real increased adverse event versus atezo-bev that we saw was a lot of itching. We saw a lot of pruritus, which generally can be managed with topicals or antihistamines. And this has led to the next phase 3 study in liver cancer. This is the first phase 3 study post current IO, and this is a triplet of tiragolumab, atezo-bev versus atezo-bev alone, with the primary endpoint of overall survival. I'm sure besides UCLA, there's probably other sites, but it's important that we try to get patients onto this study. The other big IO doublet is durvalumab and tremelimumab. Durva-tremi is 2 immune checkpoints used together, and the Himalaya study led to the approval of this regimen with durva-tremi versus sorafenib. This was a positive study. You can see here a hazard ratio of 0.78, which is a 22% decrease in the risk of death. Median survival went from about 14 months to 16.5 months. There was no change in progression-free survival. It looked very much the same with the doublet versus durvalumab or sorafenib. Interestingly, this doublet is only a single dose of tremelimumab, which is a CTLA-4 inhibitor. 1 dose of the CTLA-4 inhibitor and then monthly durvalumab is what led to this overall survival benefit and increases objective response. Objective response rate of 20%. That's higher than with sorafenib and somewhat better than we saw with durvalumab alone. And again, if you respond, you do very well. This regimen is very safe. It does not have a bleeding risk, but because you're using 2 immunotherapies, there is an increase in immune-related adverse events, and we'll see that on the next slide. So here is looking at immune-related adverse events, and you can see them listed here. All IO regimens, common things are rash, hypothyroidism, hyperthyroidism, but there is here an incidence of 20% of patients who need steroids. And if you look at durvalumab alone, that was just about 10%, right? And that 10% is what we tend to see with atezo-bev, single-agent IO, nivolumab, pembrolizumab. But a single dose of CTLA-4 actually doubles your incidence of immune-related adverse events. But again, these can be managed, and you just need to watch patients closely. Now, at AASLD, they presented this data, this regimen called the STRIDE regimen. The Himalaya study went to its final analysis, right? It didn't get stopped at an interim analysis. So they actually have long-term follow-up. And they presented here 48-month follow-up for patients with advanced liver cancer. 25% of patients are still alive, right, who get this front line. So 1 out of 4 patients with advanced liver cancer is still living out to 4 years. Even 15% of patients on the control arm are still alive. This is very different than how liver cancer was even 7, 8 years ago. Now, again, we can't identify these patients. This is not just the benefit of frontline therapy. It's an impact of all the drugs we have available now for patients. And also presented and published this year, not yet FDA approved, is a new doublet. Camrelizumab is another PD-1 antibody. Rivasirnib is another small molecule, very potent inhibitor of the VEGF receptor and other kinases compared to sorafenib. This study was positive, the longest survival we've seen in advanced liver cancer in a phase 3 study, 22 months, including patients who have VP4 invasion. So quite an active regimen. However, and this is what we question about the FDA approval, is one, this study was mostly done outside the US. US accrual was, I think, around 10%. But look at the number of grade 3-4 events. 80% of patients had a serious adverse event. And that reflects the toxicity of rivasirnib. And we'll see where this comes into play. So there's many ongoing trials using immunotherapy in the adjuvant setting. These are studies that are looking at in the post-surgical, and we talked about IMbrave 050, but there are several studies ongoing. There's also an interest in looking at these drugs in combination with local regional treatments, right? Can we increase survival? Can we improve outcomes for patients who get TACE or TARE? And just recently, there was a press release, just November 9th, the EMERALD-1 study that is looking at the combination of durvalumab, a PD-L1 antibody, in combination with bevacizumab, the VEGF antibody, plus TACE versus TACE alone, improved its primary endpoint of delaying progression. So we have not seen that data. It'll be practice changing, potentially, assuming there's a real clinical significance to move these drugs into the early stage setting. Keep in mind, these drugs are not to be used necessarily in the peri-transplant setting, right? Because using it before transplant has been associated with increased risk of rejection, right? Because these drugs activate the immune system. And this is something that's being studied in several places. And it's not to say we haven't used it at UCLA on very select patients who can't get local regional treatment. They have a risk of falling off the list. But right now, we try to get a washout of 2 to 3 months before their last dose. That is generally what's being considered. Or post-transplant, right? Definitely these drugs for patients who recur post-transplant with their liver cancer, this isn't first-line treatment, right? Because it carries a risk of rejection. And again, not to say we haven't done it, but the few patients that I've done it for at UCLA are very long out from their transplant, 5 or years more, and they've gone through everything else that's available. We've done it, and I can't say we've hurt patients, but I can't say that we've seen any activity. And again, you have patients who are on immunosuppression to prevent rejection, and then you're giving them an immune activating drug. So that's kind of like putting your feet on the brakes and the accelerator at the same time. And still, we need to figure that out. So some abstracts from AASLD. I went through every page of that abstract book. I think I might have put liver cancer or HCC. And, again, nothing practice changing, but some interesting studies. There was this first abstract that looked at cell-free DNA. So a lot of oncology now is using liquid biopsies to understand the genetics of a disease, but even using circulating tumor DNA to track tumor growth. And this study was looking at this in a liver cancer population. My colleague, Vache Agopian at UCLA, is using circulating tumor cells with a new platform to evaluate this idea. And they found in this study, cell-free DNA changes correlated with disease burden and response. And we're able to detect certain mutations in liver cancer. Unlike other cancers, liver cancer does not have targeted therapies based on specific genetics, but an interesting proof of concept study. This study by Lee et al. looked at immune checkpoint inhibitor related high-grade hepatitis and looked at several of the serum markers that you all use in clinic to make this diagnosis, and really didn't find a strong association of these titers with that diagnosis. Typically, patients need a liver biopsy to make that diagnosis. This study by Ennen et al. Looked at the risk of hepatotoxicity with immune checkpoint inhibitors, right? Can we identify the patients who are at risk? And highest risk was with dual checkpoint inhibitors. I think the data speaks to that, right? You increase the risk of autoimmunity. Also for patients who had a history of autoimmune disorders, which again is a relative contraindication to using these drugs to start with. This last study was trying to identify biomarkers for response to atezo-bev. No mutations were associated with that, but increased levels of LAG3, and LAG3 is another target being evaluated in liver cancer, another checkpoint inhibitor. Something that we aren't clear on, though we hypothesize there might not be a risk, right, is this reactivation risk with HBV. We know that risk exists with chemotherapy, but does that risk exist with immune checkpoint inhibitors, right? Because these are immune activating drugs. And they found that there is an increased risk of HBV reactivation, and that increased risk was highest in patients who had a prior taste before getting immunotherapy, and those patients who were not on prophylaxis. But in clinical trials, all patients are required to be suppressed. And lastly, this study that I thought was interesting, not directly related to liver cancer per se, but the use of calcineurin inhibitors. I mean, that's been something that's been of interest in liver transplant as it relates to cancer related death. And this study found no impact of tacrolimus exposure on the development of cancers post-OLT. So in conclusion, we've made a lot of progress in liver cancer, and we continue to. I mean, it's very gratifying. I started in the transplant or the liver cancer program at UCLA when I finished my training, or towards the end of my fellowship in 2003, and have seen a dramatic change in how we manage these patients. Patients with big tumors are living longer, they feel better, they don't have all the toxicities that we see with the TKIs, and it's remarkable. Patients are outliving their liver disease. Still, you know, there's a role for TKIs. Not everybody can get IO frontline. I'd argue that's maybe 10, 15% of patients. Patients who progress on IO need treatment options, and sequencing TKIs or ramucirumab or other drugs are important to do. And we're starting, and we'll see these drugs moved into earlier stage liver cancer, which is going to increase outcomes, which makes the most important stress on you all to keep patients well compensated, find them early, find liver cancers early, because this is a very curable disease. And there's a lot of new research ongoing. And my success would not have come without all my colleagues from UCLA. We have a great multidisciplinary program. The hepatology program has grown significantly, and IR surgery, everybody's been very supportive, and many of you, I'm sure, have referred as well outside UCLA. So thank you very much for the invitation.
That was fantastic. Thank you so much.
Some coffee up here, be careful.
Now we're going to head back a little bit to MASLD and MASH. Next speaker is Dr. Ken Fujioka, who's an endocrinologist from Scripps, and he is the director of Nutrition Metabolic Research Center at Scripps and the founding director of the Center for Weight Management at Scripps. And we're going to be learning about hormone treatment for MASH and obesity.
Well, thanks for staying. You know, a lot of people may have gone out and gone surfing or something, you know. If you get a chance, if you go to the gym, you cannot get over the view it has. Sit on a stationary bike and just look at it. It is spectacular. Anyway, it's truly an honor for me to be here, and I'll tell you why. I wouldn't be here for someone that's listed as Dr. Reynolds, Telfer Reynolds, in 1988. I was a fellow. I had completed my nutrition fellowship, and I was one of these, I did like 3 different fellowships, and I was very socially retarded, and I would just kind of do one after another. And so if you're the nutrition fellow that completed it, then you taught the GI fellows how to do nutrition. It was mainly TPN, tube feeds, things like that. And so Dr. Reynolds has me around with him every now and then. And now I'm in endocrine at this time. And he starts quizzing me, and he'll give you that look if you've ever worked with him, like, what, you don't know this? And he'd go through all the hormones for endocrinologists, PTH, things like that. And I could not get over how smart this guy was on general endo. And I'm going, this guy's a GI. Anyway, he got me into GI hormones, which has been my career of just studying all the different GI hormones and their effect on weight. So this is a very biased talk. And thank you, Dr. Reynolds, because it's been a pretty good ride. Okay, so let's talk about gut hormones and how they work. I got a million disclosures. I'm an old man. When you're older, you end up consulting for everybody. Anyway, if you ever remember this, Houston, we have a problem because they just had an explosion on their, out in space. But 50% of the US population is eligible for weight loss medications. And the reason why is 50% of the US population is going to have a shorter lifespan due to medical problems related to their weight. I mean, that's a frightening number. And as you know, the longevity of the US population has been dropping for the last several years, and it's because of this. So the other issue is that the group that many of you folks see is the morbidly obese population. So this is 2 times a normal weight. That's 10% of the US population. So again, very big number. So the take-home message is kind of odd in this one. It's not that Americans struggling, we are, but be prepared for supply issues with any treatment that really works, and you're going to see a lot of them. All right, the other thing I'm going to ask you to think of is when I was doing GI as a fellow, I would think of the signals, the gut hormones, as peripheral and working peripherally. We'll say, CCK, where it's going to go, but it's real. I'm thinking of the gut. I'm thinking of the, things like that. I'm not thinking the brain. I'm going to ask you to really think about all these hormones now, originating from the gut, but going to the brain. They're neurotransmitters. And believe me, there are a gazillion receptors for these. And the other unusual thing about many of these GI hormones is that your brain can actually make some of these hormones itself in the brain, in the hypothalamus. So it's an incredible regulatory system, and you're going to see why it has evolved to be probably, my opinion, the most redundant hormonal system in the body. I mean, just crazy. So we got to go back in time. Let's say we're here, it's 30,000 years ago, but same genetics as us. That's about how long it takes to change genetics. And we moved every 3 months to go find food. And we had to find food, otherwise we starved. And you got to remember, agriculture didn't come in until 5,000 years ago. So we just did not have a stable food supply. So our whole hormonal system was set up to feed, just constantly be seeking food. When we got food, we then release hormones that tell us to stop eating. And even there's a hormone, GLP-2, which I won't spend too much time on, which I saw they're advertising out there, that actually goes to your gut and says, oh, we've got some food. Let's grow the gut so we can get more food into the system. So again, hardwired to eat 24/7. So these are just a few of the hormones that are coming up, but there is a whole lot. But leptin, which comes from fat cells, but then the small intestine releases the vast majority of these. And we're going to go over these because you're going to have to learn some new ones, which I think you'll like, though. I think you'll get, yeah, this kind of makes sense. And then the pancreas, amylin, insulin, glucagon, and glucagons, which is going to be the new heavy hitter. And especially thanks to Julio for inviting me out. He's working on glucagon right now. So ghrelin, as you know, is the one hormone that makes you want to eat more. So I won't spend too much time on it. There is a lot of research on it, but no one has an anti-ghrelin yet. But that will be the future. But you folks may be able to get rid of it easier than any drug I can think of. Essentially, it's up in the fundus. If you take a scope and you go down, if there's some way to map these things out, which somebody's already starting to do, you can take your scope down and go and zap those and get rid of the ghrelin. Another way of doing it is sleeve gastrectomy, just trim off that big chunk of stomach, you get rid of ghrelin. So that's another future thing that I think you folks will be more involved than, say, the endocrine side. All right, well then why is it so hard to lose weight? This was a beautiful study done by Sumithran, and she basically got a group of people to lose 30 pounds in about 8 weeks. They did protein shakes and protein bars, things like that. And she tried to keep their weight stable for the next year. But even despite everyone's efforts, I mean, they had their own personal trainers, they had, dietitians, they BMOD, the whole bit, or behavior modification, they regained about 11, but they were down. And you got to remember, this is not that long ago, a little over 10 years ago, we really thought obesity was a temporary problem. We had no evidence that there were changes that would make your weight go back up. Well, she was about to disprove everybody. And so if you look at ghrelin, the one as you're looking at it, it would be to your left up. You can see the black line is where they start. That's baseline. But notice at the end of 10 weeks and 62 weeks, it's higher. So they're driven more to eat. This is a year later. PYY, which is the most potent of all the satiety hormones, it's very hard to work with. I worked on it for almost 7 years, but it was you were so satiated that you were vomiting. It was just, and it still may eventually make it, but I never could get it to work. You can see that at the end of 62 weeks, it's lower. So in other words, they would eat a meal, but they wouldn't bring as much of the satiety hormone up, so they weren't as satiated. They weren't as full. They wanted to eat more. And again, this happens a year later. It also became clear to us, oh my gosh, these are permanent changes. Your set point is not something that you can move down. You can only move it up. So if you get to this is really tough on women who gain a lot of weight during pregnancy, because that becomes their new set point. And again, it stays with them forever. Men, let's say you get hurt, you get an injury, you can't exercise, and that's how you kept your weight down. So you gain 20 pounds. That's your new set point forever. Boy, isn't that, I know. Okay. Do we have a Prozac booth out there? Okay, good. All right. So yeah, that's right. Believe it or not, there is a good ending to this story. So I'm going to ask you to really just think over the long haul that, yes, you lower your satiety hormones, you drive up ghrelin. Here's some more bad news. I promise this is the last of the bad news. So we've always known, and actually the most beautiful study, I don't know if you ever watched The Biggest Loser. It's a crazy show where you get money if you lose a ton of weight. And they've actually studied this group just like this. But anyway, let's take, a guy who's 6 foot tall, he's about 200 pounds, maybe a little overweight, and he probably burns about 2,000 calories per day, and he probably eats about 2,000 calories a day, and that keeps him weight stable. But let's say he has a friend who's just a little bit bigger. They're both 6 foot tall. They both have the same, roughly muscle mass and all that, but he loses 20 pounds. So now he's 200, just like his buddy. His metabolic rate is 1,700 calories per day. In other words, it's lowered 300 calories. And the bad part is it will be lowered until he gets back to 220. So again, another thing the brain is controlling through what we're going to learn in a second, some of the satiety hormones that are coming up. When they looked at The Biggest Loser, now these folks are losing on average 120 to 140 pounds during the show. I mean, that's a huge amount of weight. And their metabolic rates drop by like 7 to 1,000 calories per day, 700 to 1,000. It's just phenomenal. They get cold really easy. All kinds of things happen. All right. So the future is going to be replacing these satiety hormones to tell the brain it's okay to be at a lower weight. And so we got a whole host of them. So this is all the things out there. If you just want to, take a picture of one slide, this is probably the $1 million slide. And I probably should have saved it for the end, and I had to change it literally just a couple of weeks ago because, as you know, tirzepatide was just approved for obesity treatment now. And we're going to use the gold standard as sleeve gastrectomy because, and again, the presentation, I think there's a couple of them really good, showed the bariatric surgical data, which is phenomenal for fatty liver, but it shows the more you lose, the more you get. So, you get 20% weight loss. Wow, you're hitting some big time home runs. So sleeve, yeah, 20 to 25% on average. It may be a little bit less than that, but pretty darn good. Semaglutide, which we're going to talk about in a second, 17%. I'll take that. And then tirzepatide, wow, 20 to 22%. So now these newer hormone treatments are approaching surgical numbers. Phentermine topiramate is in there. I will tell you, at the dose they're using, it is hard to use. A lot of side effects, so I don't recommend it. Oh, whoops, I'm going to back up just for a second, because guess what? There is a GLP-1. This is kind of a low number, liraglutide. The reason why I'm going to say just keep in the back of your mind, it goes generic in June. Oh my gosh. Okay. All right. Sorry, this is an exciting field, and I kind of sad that I'm near the end of my career and I don't get to try all these new drugs and stuff. But anyway, so you have L cells, and I spent a good part of my career studying the L cell. So the L cell is a fascinating cell in the small bowel. It's in the distal small bowel, so it's pretty far down. It's mainly in the ileum, and on one side, it's in the lumen of the gut, and it's tasting food as it comes down. It tastes fats, proteins, and carbs. And a little secret here, the one that will get it to release the most amount of GLP-1 is protein. So I don't think protein diets are ever going to go away, high protein diets, because they release so much more GLP-1 than the fat releases almost zero. It's really kind of sad. Anyway, so it tastes the food, it releases it, it sends it up, and it'll go to the pancreas and say, okay, we got food around, you better start releasing insulin. It'll go to the brain, say, I'm full, there's food. That's why it's pretty far down. It's kind of like the ileal brake that I was taught in med school. Goes to the pancreas, lowers glucagon. So that's why it's such a good diabetic agent, and hence why it started there. And I want you to keep this in the back of your mind. You got to learn some, physiology here. It works through the liver, and then glucagon is going to improve hepatic glucose output. The other thing, and this is the big one, and this group, I don't need to teach this because you probably get tons of referrals on this, but when I'm talking to internists and endocrinologists, they don't realize how much it slows gastric emptying. I mean, it's very impressive. And, nowadays it's a lot easier to do these studies, but you just swallow a pill and you can follow through and you can find out the gastric emptying time very easily. All right, so this was the study that just blew everybody's mind. It's New England Journal of Medicine. And I'm going to kind of teach you how to read these weight loss studies, because you're going to have to do it. And it doesn't show up as well as I would like it. But when you look at the slide, you look at the top one, that's just the weight loss for all comers. So in other words, some patients dropped out because they had side effects. Some people moved, whatever. And they do their best to get the patients in at the end. And the bottom is the patients who take the drug the whole time. And anyone will tell you, we've never seen compliance like we've seen now. Patients are compliant with these drugs because they lose weight. And they also get some input. If they forget to take it, it's once a week, right? They all of a sudden start to get hungry that second. Oh yeah, I forgot, I better inject it. So it's an interesting setup that, again, I've never seen with the drug, because the old weight loss drugs, we were happy if they stayed on for even 8 weeks. Patients are staying on these things for months and months and months, and they're good about taking it. But if you look at and it may be hard to see, the top graph, you'll notice it comes down, looks like it levels out, almost looks like it goes up a little bit. It's really not. What it is we pay people, usually $300, sometimes more, to come back from wherever they are, wherever they moved, and just get what we call safety data for the FDA. The FDA hates when you have dropouts and you don't know what happened to them. So we bring them back, we pay them to come back. So the number of patients at the last visit is actually higher. But those are the patients who didn't lose weight because they couldn't take the drug for whatever reason. And so it looks like it blips up. You look at the bottom line, the people who kept taking it, basically that number is still going down. So again, that's how you read it. The other thing is, and again, sorry, I should have divided this up into smaller slides. Again, who gets bariatric surgical weight loss? More than 20%, roughly 35% are getting that. So again, in the best of hands, these patients are doing very, very well. And obviously, despite how good these drugs are, if you diet and if you exercise and change your behavior with it, you get that much more weight loss every single time. Very, very impressive. All right, come on. There we go. All right, side effects. And again, I'm preaching to the choir. As you can imagine, they're all GI. They're almost all related to slowing of the gut. And this is a complicated issue because the natural response, think of your gut as this 27-foot metabolic monster that just needs energy and calories. It's turning over cells rapidly. So it has a very high metabolic requirement. So when you start losing weight, you actually slow your gastric motility all the way through. And hence constipation is extremely common. But obviously the nausea from the gastric emptying is slowed down. Vomiting is, usually it's young males who overeat when they're on a GLP-1. In other words, they just haven't learned yet to, order, just a simple hamburger. They're still used to ordering the double, triple, and fries and shakes. And so, yeah, they're going to throw up. And if any of you guys want to make a New England Journal paper really well, figure out why you get diarrhea with these. It's just a struggle. It's a cyclic diarrhea. They'll get constipation for 2 or 3 days and they'll get diarrhea for a day. They'll get constipation for a few days and they get diarrhea. But nobody really knows the real reason why. So remember earlier we said it's a permanent set point. So in other words, whatever's the highest weight you've been at, that's the new norm for your brain. So what happens when you stop these satiety hormones? Yeah. So you can see that curve, the orange line's coming down, dark blue, they're still losing weight. They lose out nice 16, 17, 18%. But when they stop it, you see that, and this is the best diet. They got their own personal trainers. They hired these guys with these pink thongs to really work everybody. And you just see it just slowly coming back up. It's like, oh man. And again, it's because the brain says, no, I'm going to get this weight back metabolically, hormonally, because I think I'm starving. I think something's wrong. I'm not at my highest weight. All right, let's talk a little bit about the liver. And, this is really hard because all these studies are done very differently. It's kind of like comparing apples and oranges. And I'm going to kind of stay away from stiffness and fibrosis and stick with just percent fat loss. And that's the best way I can look at it. There are some other studies that are, I think, are pretty good. But again, I feel like I'm a little out of my realm with this audience. I'd say to endocrinologists, I'd talk to them about it. Anyway, you see that bottom two on the bottom right, so they start off with roughly 17.5% fat in the liver. And you can see they get it all the way down to 7.5. So they lose over 50% of the fat. Numbers, everything gets better. The stiffness doesn't change all that much, but by 48 weeks, it's pretty much there. So if you get that kind of weight loss, you may have reached your nadir and you're there and you're doing it. Keep that number in your mind, 17.5% fat down to about 7. So they lose, 10%, or in other words, over 50% in general, because again, we'll try and compare apples and oranges with some of the other studies. All right, so what's the future? The future is basically just combining as many of these satiety hormones as you can. And so now you got to learn another hormone. Now, this is one I literally heard about when I was with Dr. Reynolds way back. We called it just an incretin, but it was actually called gastric inhibitory peptide. You're going to see the endocrinologists are going to try and change the name because it does work on the pancreas to lower glucose. So, and it's in a different part of the small bowel. It's not in the distal, it's in the first part of the small bowel. So it's in the duodenum, first part of the jejunum. Whereas if you look at K cells, they're way down, L cells, which have GLP-1, they're way down in the ileum. So they work in concert, one and then the other. But like GLP-1, it goes to the pancreas and says, make some insulin. Goes to the brain, says, I'm full, I don't need it anymore. Goes to the alpha cells, lowers glucagon. And again, does this through the liver. But it does not really have that much of an effect on gastric emptying. Its effect is on gastric acid, so it lowers the gastric acid secretions. So again, different kind of animals here. Okay, come on, orc. Oh, so here's the neat thing about, though, and this is why we think with gastric bypass, you get such severe hypoglycemia, is that GIP is a unique, I don't know, I know of no hormone that can do this, but it can actually go two ways on the alpha cells. It can either, if your blood sugar is high, it'll lower glucagon. But if your blood sugar is low, it will raise glucagon. What? I mean, that's pretty impressive to me. And how it does it, I don't know. It's pretty advanced. Okay, come on, here we go. Okay, so tirzepatide, as you know, just got approved a couple of weeks ago for weight loss. It's basically GIP with a GLP-1. And, you know, your standard randomized, double-blind, huge study, 2,539, and they looked at 3 doses. This is great, and I'll tell you why. Semaglutide, which is already out and has been out for a while, they only have really 2 doses at the very high end approved. This gives you a lot more options because for a lot of patients, you're not going to need big doses. For me, you know, especially my diabetics where I've been able to use it for a couple of years, little old ladies respond so well to this that I'm using the lowest dose possible just to maintain them at a normal weight. And I don't want them to get too thin. All right, so you have to step it up and notice the step, 2.5, 5, 7.5, and it's monthly. And the reason why you need to know about this titration is all the problems are going to happen when you're titrating. In other words, the nausea, the vomiting, all that kind of stuff. So don't be afraid to take longer than a month. This is when we do these clinical trials of this level of a phase 3, the FDA says, look, you got to do a forced titration. They either drop out or you stick with the titration. But they say, but we don't want to hurt you in clinical practice. You can do it however you want. So don't be afraid to go much, much slower. Okay, the weight loss, and these are completers as you look at the graph, but look at that graph. It just comes flying down. Wow, over 22% weight loss. So now we're easily in surgical range. The 2 doses, the 10 and the 15 are pretty darn close. The 5 is still really good. I mean, you know, 16%, I'll take that anytime. And you may end up having to lower the dose because they lose too much weight. And I never thought I'd ever teach that in my career. Okay, so I got to teach you another concept about weight loss. So let's say I take any, you know, you overeat, we put you on some beta blockers and things like that. And so your weight goes up 40 pounds. So we bring your weight down 40 pounds. You don't lose 40 pounds of fat. Anybody, no matter how you do weight loss with diet, exercise, whatever, you're going to lose about 10 pounds of lean tissue, which could be anything, bone, muscle, you know, plasma, whatever, and 30 pounds of fat. It's that ratio. That's normal. And as you know, social media, which drives all of us crazy because your patients will send you a task every day. Well, on social media, I heard, and they are always saying, yeah, that you lose too much muscle. There must be some people out there who really hate these drugs. So they make up all kinds of stuff. But anyway, the weight loss is what it would be expected. It's not more muscle loss than you would expect. And it's every study I've seen that says, oh, there is more, did not borne it out to me. And if you do MRIs of the actual muscle, you actually are sucking fat out of the muscle, which lowers the muscle mass. So it's a little bit complicated, but in essence, we're not seeing more muscle mass. And you can take that to the bank and you can tell your patients, no, don't worry about it. Okay. Oh, and they did this in the elderly too. They did it with semaglutide, a guy named Bob Kushner. And obviously, because I'm over 65, I'm really curious, well, what happens when I do this? Am I losing too much muscle mass? No problem. Again, these drugs are not producing too much muscle mass loss in the elderly as well, which is giant. All right. When I'm switching from my career essentially was every morning I did clinical research, every afternoon I saw patients. So when I'm switching to my hat of clinician and I'm learning a new drug, I would always read the adverse events that lead to discontinuation, because these are the problems you're going to see in your office, and patients are going to, they complain enough of them, they want to stop. So you can see that nausea, you know, at the lower dose, you know, 1%, 1.1, 1.9 for the bigger doses. And it is a little bit dose dependent in that the 2 bigger doses clearly have more adverse events that lead to discontinuation. If you look at the bottom line, all GI events that lead to discontinuation, it's 1.9 versus 4.4, 4.1. So again, that 10 and 15 are awfully close. And I was, when I was looking at this data a long time ago, I was kind of surprised that they went with the 15 because they do so well with the 10. But, every little bit helps. This is just to tell you that if you look at these graphs, the 0, and you just go all the way up to 72, those are months. Excuse me, those are weeks. And you see that the events all happen in the titration in the beginning. Be prepared for them to happen the very first week. So again, you may, instead of taking a month to go before you go to the next dose, take 2 months, take 3. And the reason why I say that is if they start getting nausea, it means it's working. It just means they're really sensitive and they're going to lose weight. It's not going to slow their, it might slow it down a tiny bit, but more than likely, they're going to lose them. And they're going to say, no, I can't do this. It's just too horrible. So again, go slow on your titration. Looking at fatty liver, and again, this data was just showed, this is the eventual paper that came out of the abstract that was shown, I think, again, 2 talks ago, very well done. You see, so when you look at the VAT, visceral adiposity, you can see it just goes down. The more you get in terms of visceral fat loss. But they got into problems when they looked at the 10 and the 15 because they weren't really that much different. So they ended up combining them and pooling the results. But you can see that, they lose roughly 8% with this. So do you lose any more percent body fat? Again, apples and oranges. Again, if you look at semaglutide, it was 10%, overall. But who knows? Maybe their percent body fat was lower. It wasn't 17, maybe it was 15. Other studies, it could be 20%. So it can vary in there a lot. Insulin's funny because insulin, as you know, a lot of times they use it as an active comparator. If your blood sugar's out of control, you just get worse fatty liver. But if you give a lot of insulin, you get worse fatty liver. So it's kind of this push-pull problem. All right. One, just a real quick one, but you are going to see it. It's cagrilintide. So it's a hormone amylin that comes from your pancreas. And it will, all it does is only does 2 things. It suppresses glucagon, slows gastric emptying. And very tough to work with the old form because, again, it slowed gastric so much. We just saw just tons of nausea and vomiting. Fast forward now with the phenomenal biochemistry that these pharmacokineticists can do is they've made it a once a week. So you don't get this big peak when you inject it every day. We were injecting it 3 times a day with each meal. That's how short acting. And always remember this. The own native GLP-1 that you guys make, your satiety hormones, try and guess what their half-life is, the stuff you make. 90 seconds. 2 minutes, 3 minutes, really short. Literally, we were evolved to have this minute-to-minute regulation of our food intake, which is fascinating to me. But pramlintide is no different. So fast forward, though, now they got something. It doesn't go up to a high peak. It just stays slow, and it's tolerable. And, very short study, 20 weeks. But again, this is going to come. You can't get over how these guys are all just clamoring to get these things to market. 100 patients, multiple doses. And in just 20 weeks, they're getting 17%. If you compare it to what you normally see would be 10%. Wow, that's phenomenal. All right, glucagon. You got to learn this one, guys. This is the big player. And it's going to be right up your alley. So it's secreted by what cells? Yeah, the alpha cells. What is glucagon secreted to? What do you secrete in response to? Yeah, hypoglycemia. And fasting. Fasting is the other thing that will do it. And fasting, humans really were meant to fast all the time. That's why this time-restricted eating or intermittent fasting is so popular, because it works. And how does it do it? Where does it go? Yeah, it goes to the liver, stimulates glucose production. But I'm going to ask you to think outside of that. Don't just think glucose. It's going to stimulate energy production. It's got to get energy for the rest of the body. And it obviously inhibits beta cells. Some things you may not know, which makes no sense to me, because if you're low in blood sugar fasting, you'd think it wouldn't be a satiety hormone. Guess what it is? For whatever reason, the way we evolved, it tells you I'm full, stop eating. Well, here's the best part. Increases energy expenditure. Oh, you got to love that. Increases lipolysis. So it's very targeted towards fat and increases utilization of the fat. So hence you see a decrease in body weight, which, and in particular fat mass. So it's very good. So the only reason why I bring this one up is because I just pimped the residents and fellows on this like crazy. But looking at the brain, which we said is trying to control a lot of this through the liver, what are the only two things that the brain can run off? They can't run off fat, I can tell you that much. That's right. Ketones and glucose, that's it. So we think that signaling is from the brain is that, okay, look, I need energy. We're fasting, I'm running out, I got to have something. And it goes to its favorite organ, the liver, because it has the biggest stores of glycogen. And for a while, you can start making it and it'll mobilize it with the right hormones. And it does that with glucagon. But the other thing it can do is any fat in the liver, it can take that and turn into ketones, which makes the brain just as happy. So again, think of energy, try not to be quite so macronutrient centric. The other thing is it'll also signal to the fat cells. I had a great talk with Julio on this mechanism. And we really think at this point, metabolically speaking, that glucagon, it'll empty out literally, the fat out of the liver if it has to, but then it'll start going to other places. So again, for me, trying to get someone's weight down couldn't be better. And we also know it engages the right receptors. All the markers, everything is there. And again, I can't say too much, otherwise I have to kill you. Okay. All right. So the latest one is this. And you're saying, well, Ken, why are you showing me this data? And hang in there, because you're going to say, oh, I'm glad you told me about this one. So yes, it is a hormone analog with 3. No, it's not a rap singer. Anyway, GLP-1, GIP, and glucagon. So you're just loading up on everything. And it's those 3. Don't worry about how strong these things are, because remember, the way the pharmacokinetics are is that you take it and it just keeps a stable level. You're not going up and down like how we normally do when we eat meals. So you're getting a much more powerful effect than you would with these like single dose injections. Obviously a phase 2, because they're using different, parameters on, okay, we'll just ramp it up really quick. Oh, no, we'll ramp up really slow. We'll see how many patients we lose. But they looked essentially at 12, 8, 4, and 1 milligram. So they're trying to find the maximally effective dose and the minimally effective dose. And again, just to keep in the back of your mind, glucagon increases energy expenditure, oxygen consumption. And it's one of the few things where you can take your white fat cells, they look kind of yellow, and you can turn them into brown adipose tissue that you can burn. Glucagon's very good at that and increases fetal cycling. All right, so the weight loss was good, but you're going to see some things on this that just blew everybody's mind. But wow, 24% weight loss. That is just, again, now you're talking gastric bypass numbers. And the group that we think obviously that needs the most is BMIs of 35 and higher, because these patients have so many metabolic issues, they're really struggling. And you can see they get even better weight loss, 28.5%, 26, 27. Wow. And here's the last one. It shows you, so women have a harder time losing weight because of metabolic issues. They just don't burn as many calories. They're very good at adjusting their hormones because, they get pregnant, they have kids. They are much better equipped to survive starvations than men are. So they have a harder time losing weight. I mean, they really have to work much harder. But because you're changing the hormonal menu, we've never seen this before, the women lose more, 28.5. Oh my gosh. So again, it tells you you're working at a high metabolic level. All right, so why am I making you learn all this stuff? Bootleg. So these things, including the one I just mentioned, so triple G, tirzepatide, semaglutide, these are being sold in the US by unscrupulous physicians. And what they're doing is they're buying it from usually China or India. It's being made. The way you can ask your patient if you want to know, they'll tell you, yeah, they have it in a vial. None of the companies sell these things in vial. They're all in pens. Pens are expensive to do, but obviously easier for patients. But what they do is they go to usually a nurse. and there's doctors running multiple of these clinics. The nurse takes the vial out, they'll draw up however how much they think they need, and then they'll inject it once a week. They pay $80 to $120 cash for this injection. And then they try and talk them into some B12 injections, which don't work. And they end up paying about $150 to $160 per month. You can imagine this every week they go. And remember, when you don't get it, hunger comes back, they go running back. This is a bad situation. So long story short, all three of those are out there already. And if your patient says, oh yeah, we saw him drop from the vial, think this is not good and let somebody know. All right, so sorry I ran over, and I won't even summarize. Thanks for listening. I really appreciate it.
Okay, so we're gonna have our panel now, so all the speakers. Tim, you weren't on the list for panel, but I think you should come up. I'm sure there'll be some outcap questions, and also we have some guest panelists. Mina Rakoski, who's from Loma Linda, Jasleen Singh, and Akshay Shetty, who are both from UCLA. And I'll get another chair. And we'll also have maybe some people that are remote have some questions. Sammy.
Black and people taking prednisone for alcohol hepatitis? Given the rate of infection so high?
So I think it's on. The question was, do I recommend prophylactic antibiotics in people taking prednisone? No. You know, there was a study where they gave prophylactic antibiotics as a treatment. It was a prospective randomized trial with the idea that you could prevent infections. And you found, now I don't know, I can't remember if they got prednisone at the same time, but there was no survival benefit with prophylactic antibiotics in alcoholic hepatitis.
And how about that subgroup that has ascites and alcohol hepatitis? Think they may benefit from antibiotics? Because I worry about them.
Yeah, I'd have to think about it, Sammy, but that's a great question.
All right, thank you. And a question on fatty liver. What is the role of the microbiome in fatty liver and NASH and weight gain?
Very good question. I did not cover that data. There are definitely some very positive data about microbiome for NASH, NAFL treatment, muscle treatment. And there are also some data about even fecal transplantation for weight loss and improve of inflammation. Yeah.
Thank you.
Hear that?
Hi, thank you. Excellent talks. Couple questions for a couple people. One is, if we're going to be monitoring so many people with fatty liver and finding a lot of fibrosis, cirrhosis, and improving that, hopefully with the different medications we have, once a person has like F3, F4, and then it improves, is that person going to be on the surveillance for liver cancer forever, despite the improvement? Once they have a scar, is it always going to be a risk for them? Second question is, are we going to be seeing any, or do we know, I know they mentioned data is coming out in like 2025. I know with these medications, you can't use it in patients with history of medullary cancer or family history. Are we going to be seeing any kind of pancreatic cancer or any kind of all this stimulation to the pancreas? Is there going to be a worry about that and with all these patients on this medicine?
So regarding fibrosis regression, yeah, that's very good question. And I think the data for fibrosis regression from clinical trial, that's what they're targeted to. I think there's no FDA approved medication, but for bariatric surgery, the data could achieve fibrosis regression and NASH resolution. So once they achieve fibrosis resolution or regression from stage 2, 3, or 4, to below 2, should we screen for liver cancer? Or I think that's a very good question. I mean, theoretically, we don't need to, right? And the data for, liver cancer, we definitely have the data for liver cancer with obesity. And even without advanced fibrosis, they can develop liver cancer. And the prevalence still very low compared patient with advanced fibrosis and cirrhosis. And so the current recommendation from AASLD still is in the population of cirrhosis to screen for liver cancer. So I think theoretically, we don't have data, but theoretically, if the patient really prove they have fibrosis regression, resolution of NASH, just what we had done in the patient with hepatitis B and viral hepatitis C, and then they have a sustained resolution of disease, they shouldn't proceed for liver cancer screening.
Thank you.
Push the button. There we go. On the issue of pancreatitis, that's a very real issue. So every single study, either one I've monitored or have done, you see this ratio roughly. If you just take 100 obese patients and you give them GLP-1s, they 1 out of 1,000 just get it spontaneously. That's the natural history of it. But if you give them a GLP-1, it's 2 to 3 per 1,000, and it's very consistent all across all the different ones. With that said, no one has seen any hint of cancer, so that's been really good. And they've been monitoring this very closely in these large cardiovascular outcome trials. So looks like no cancer, or at least no signal of it. The other thing, that the pancreatitis is very different from anything I've ever seen, in that when they get it, and again, it's just that little change that they make is enough to bother the pancreas, and they get pancreatitis. The patients may not complain of the really severe pain, radiating in the back, vomiting across the room. It's going to be really mild. It's just barely epigastric anything. And they just, it's just kind of sore, and they don't want to stop because they're losing weight. But if you get an amylase and lipase and they're elevated, yeah, you probably should stop.
Thank you.
Morning, excellent talks. Question about the GLP-1. Seems it's a new kid on the block for weight loss. We have a lot of patients with IBS, whether constipation or diarrhea, and one of the most side effects that led to discontinuation was constipation or worsening diarrhea. So how do you foresee the use in that population, or what's the advice you would give us?
It's a tough one because you can actually make it worse. That's a real issue. The other drug, so I didn't talk too much about GLP-2, which is approved for short bowel syndrome. We looked a lot of that, and because GLP-2 is even better at slowing down gastric emptying and GI motility, that if that's the reason for the bowel problems and issues, then it's going to get worse. If it's not, then you're probably going to do okay. The other thing is, if there is the inflammatory factor you're worried about, every single study shows that when you take patients and you get them to lose weight, their inflammatory factors just drop really nicely. So if it's the inflammation side, okay, you'll do better. But if it's motility, it could get worse.
One comment about surveillance for fibrosis regression. I think Dr. Pakros published a paper on Hep C, regression of fibrosis after treatment with DAA. The risk doesn't go away, it just decreased, but it's still there. So we should continue screening is a message. For Dr. Finn, last question about liver cancer, so you don't feel left out.
Yeah.
So when you hinted we should be detecting liver cancer at an earlier stage so we could treat it better and easier. But the rate of surveillance is quite poor still in the community for liver cancer. So I think we should aim to increase surveillance awareness before we aim of increasing the need to treat early.
For sure. I mean, I see the end result of that, but I always lecture the residents. I mean, you can't find liver cancer unless you find liver disease. And let's be honest, there's a huge under awareness, and it's gotten better now that we have good drugs for Hep C. But there's, and also NASH now. I mean, so many patients I see with advanced liver cancer, I look back, they had a platelet count of 110 for a decade, and no one looked for that, and no one worked it up. patients who came from Asia and have lived there their whole life. They've had a colonoscopy, a mammogram, but no one's looked for chronic Hep B. So I agree 100%, but even before looking for liver cancer, we need to look for liver disease.
Great. Thank you.
There was a quick question actually from the virtual world, and I guess for Dr. Finn or others, if there are any mRNA vaccines for HCC that might be on the horizon.
Yeah, I mean, the power of the immune system to fight cancer is just starting to be scratched. You know, there's a lot of cellular-based therapies being developed. These, and again, everything is very early, phase 1. These would be T-cell modified treatments towards tumor antigens. There's antibodies being directed against tumor antigens with drug conjugates or radio-labeled antibodies, and these are against proteins that are differentially expressed between normal liver and liver cancer. One of the targets that's being pursued is glypican-3. It's been around a long time. It's used as an antibody to help in diagnosis. And along those lines, just like Moderna and BioNTech, initially, even before COVID, were a big priority for them were cancer antigens. And that will be coming in the future as well. Still, I think they need proof of concept. There was a study recently in melanoma, I think with Moderna and pembrolizumab against a melanoma antigen that showed, you know, potential synergy. So eventually in liver cancer.
Hi. First of all, that was an absolutely fantastic morning session. I had a question for Tim. The little data that showed the transplant survival after transplant, it always worried me that number one, 25% of people that they thought would die actually lived, and then their post-transplant survival seems to be much lower than I would have expected. Do you have any idea why that is?
Well, so is this on? You raised 2 points. One is, you know, are we wasting a liver in somebody that's going to survive anyway? And that's a major issue. So, and I don't know that anybody's been able to pin that down so that we really, in the control group, the mortality would be, you know, 90%. So you're only wasting 1 out of 10 livers. In terms of the mortality and among the people that got transplanted, my memory is that go back and look, quite a few people ended up with aspergillosis in the lungs, and it was kind of an outbreak in their unit. And so I think that was part of the problem. I'd have to go back and look at the slide in the survival in the prospective study. And certainly it was the same as if they had waited and for 6 months of sobriety. So I think that there was something specific about the first trial with decreased survival.
Thanks.
We have another question from the virtual world, actually, I think for the endoscopists in the room. If they're holding GLP-1 agonists before upper endoscopies. I know that's become a big issue with the anesthesiologists.
I am holding GLP-1 agonist and holding for 1 week prior, just because of the theoretical risk, and it doesn't portend risk to the patient to hold for 1 week. So that's what I've been doing. You know, my colleague also scope.
Yeah, I've been doing the same thing. I've been holding it for endoscopies with it for a while.
Yeah.
I have nothing new to add because I also, for those that administer it once a week, we've been holding it for 1 week prior to endoscopy as well.
And I think for the orals, I think the recommendation, at least through anesthesiologists, I think 2 days, but I might be wrong on that.
Great session. Question for Dr. Finn. Any comments on liver transplant for metastatic colorectal cancer? I looked at the abstracts and there was only one. I don't know. And looked like Europe has been doing them quite a bit.
Yeah, it's very
and
good.
Here we are starting. Could you comment on that?
Yeah, it's very good to see you, Francisco. It's been a long time, and I'm very happy to be with you again. You know, this is the utility of the use of a liver, right? I mean, if we had livers for everybody, there's probably select patients with different isolated malignancies that might benefit. You know, colorectal cancer to the liver is a very unique metastatic site for that disease. We know some patients are cured with resection, but I think the idea of using transplant widely for these patients is not going to come anytime soon. You know, cholangio, there's patients who have cholangio who aren't transplanted routinely, and I would argue that that disease should come to the forefront of transplant before colorectal cancer, but it's all patient selection, right? There's some patients who have indolent disease in the liver for years and probably would do well with a transplant with colorectal, but I don't see it happening anytime soon.
Okay.
In the US.
The role of SBRT for HCC.
So SBRT is just a destructive therapy, right? Very similar to ablation in principle and concept. Some institutions have very strong radiation oncology programs. Some have very strong IR programs. Still, there's not high-level evidence for SBRT, but I'm sure for smaller tumors, it probably is effective at treating the tumor you see, right? And maybe as a bridge to transplant. But I don't think it's going to replace microwave or other percutaneous approaches broadly anytime soon. It's still not, you know, level 1 evidence for that approach, but there's no reason to think it doesn't work for a small tumor. It's just ablative.
Thank you.
I'd like to ask the other transplant hepatologists about their thoughts on colorectal cancer medicine and liver transplantation.
Yeah, I think USC started protocol for you know, colorectal cancer, metastatic liver for liver transplant. Just like Dr. Finn, the criteria is very strict, and because those patients actually, the disease, many times they are in remission, and the treatment toward liver metastasis, like large resection, ablation, and chemotherapy, they have been experienced, they need port hypertension and complication of port hypertension. So those patients actually very behave like decompensated cirrhotic patient with bleeding, variceal bleeding, ascites, those issues. And I actually in liver meeting with the transplant course, those in Europe, they report the transplant outcome. They're doing quite well with strict selection criteria.
I think that's a great topic to discuss. I think the world of transplant oncology is coming our way in the world of transplant in terms of transplanting intrahepatic cholangio, neuroendocrine tumors, and then colorectal metastases. So there's actually a great presentation, as she mentioned, at AASLD looking at this topic, specifically transplantation for colorectal mets. And so I think with excellent patient selection, there have been good outcomes. I think the other key will be really great collaborations with our oncology colleagues, our interventional radiology colleagues, because I think it's going to have to be kind of setting the bar that recurrence may be sort of expected because this is such a high risk transplantation, and to make sure we have all of those integrated collaborative work post-transplant if recurrence occurs to make sure we have a plan for them.
Jasleen, Akshay.
Yeah, I mean, I think with excellent patient selection, it would make sense to consider some of these patients. I think just from a perspective of, you know, our patients with liver disease, even with intrahepatic cholangiocarcinoma that are in need of transplant, you know, when you're also increasing the pool of potential recipients, you know, we also have to think about how many donors are available for these patients too. So I think that's just something to consider moving forward.
Yeah, I think I'd like to echo Finn's points on this. Is that, you know, I think it's a new and emerging field, but without having sufficient donors, it's probably something that's going to be difficult to successfully achieve at majority of the centers. There are probably select centers who are going to succeed at it, but it's probably going to remain a challenge.
This may be a good topic for next year, actually, a talk on these newer indications for transplants.
Great presentations by everybody. Thank you. I have one of the slides you showed in the MASH talk was from Stephen Harrison's paper, where it basically proved that hepatologists and other providers can't find a MASH patient most of the time. I mean, you know, the screen fail rate for most of these trials is over 80%, sometimes 95%. So, you know, maybe for any of the hepatologists, like, when we do have liver-directed therapies, what's going to be the threshold to want to start that if most of the time we're wrong about a patient actually having, you know, F2, F3 MASH with a very active disease? And so maybe Dr. Singh, or what do you, because she's looking right at me, she has something to say.
I do. I mean, I think I have a lot of questions actually about these emerging liver-directed therapies, just, you know, whether insurance companies are going to require something like a biopsy. I think that, you know, honestly, as hepatologists with MASH, I think we take a lot of things into clinical context. So whether we're overestimating fibrosis is, I think, something that we always consider, but by taking a patient's entire clinical context into account, I think will allow us to, I hope, be able to appropriately allocate those resources. But I think there's going to be a lot of, you know, questions that come out when hopefully there is a new medication that's approved.
Yeah, I think like this AASLD like meeting, they actually have massive data regarding non-invasive testing, how they were correlated with liver biopsy, and also those clinic trial, what they have done with the liver biopsy. And they also have MRI data, FibroScan, FAST score, and also non-invasive marker such as Pro-C and sex hormone binding globulin. So all this data, they try to looking for whether this non-invasive testing and marker can replace of liver biopsy. I still think it's really it's getting very close, and because they have very good correlation and outcome correlated liver biopsy. Liver biopsy, of course, is very not practical. It's not very invasive. It also have pathology. Every pathology read a little bit different discrepancy of about NAFLD activity score, fibrosis score. But this non-invasive testing show very good promising to replace liver biopsy. On the top, I think, as you mentioned, it come from primary care clinic, not from hepatology, was referred. But I think we have very good gauge of FIB-4 score and algorithm screen with non-invasive testing narrowed down, which with high risk of high-grade, high-risk MASH patient with advanced fibrosis. I believe if we do have FDA approved, those is the algorithm we're going to approach to treat patient and monitor patient.
So we're just about out of time. So we have time for 3 questions from John, Nora, and Chuck.
Congratulations. It's a great morning of talks. I think it was at last year's meeting, there was a talk about endoscopic duodenal mucosa ablation for management of diabetes and improved glucose. Can you comment? Because it seems like that would ablate the cells responsible for GIP.
Thank you. Yeah, no, that was a hot topic. A lot of people doing it. So they're basically just relining the duodenum. And I have to agree with you. It seems almost counterintuitive because you're getting rid of your K cells, which are, again, they're going to do some tasting. I guess, to me, I never saw a good reason why they thought it was working and why it was going to do what it did. So I haven't seen much since then. There's just not coming out on it. So I may not make it.
Really, I have 2 quick questions. I promise quick. Okay. All right. The first is around GLP-1 receptor agonist. This is just such a hot area. I came from a conference where that was like really the talk. But I'm interested in its use in AUD. So there's a very interesting sort of publication very recently showing that individuals who have AUD plus who are trying to lose weight, who are on the drugs for obesity, actually have decrements in their alcohol use during treatment. And there is some central effects, of course, with GLP. So I think this is an actually really interesting area and wondered if you want to just speak to that. It seems like it's data, there's a paucity of data, but in terms of just this being a potentially new area, because we lack really good therapies for AUD. And Tim, maybe you could comment on that.
Okay, so the system I told you about is, think of it as like the main hypothalamic driven system that controls weight. But we don't always eat because we're hungry. And the classic is you go to your favorite restaurant and you've eaten a nice entree and you're not hungry anymore, but the waiter comes by with a tray of, say, your favorite cheesecake, and your brain goes, well, I've got to have that. And so that's called reward eating. And it's a different part of the brain, nucleus accumbens, other areas that deal with reward. And there's 3 hormones involved there, which actually aren't GLP-1. They're norepinephrine, dopamine, and opiates. With that said, it turns out there might be some GLP-1 receptors on those reward centers. So you're correct. They consistently see, with all the studies, decreased alcohol intake. And so they're guessing there's overlap. I will tell you, though, it's not as strong. So you can give, like say naltrexone, something that's directly, going to hit opiate receptors and things like that. And they may actually be doing a little bit better. But with that said, and again, we only did a few studies on alcohol intake. We mainly did ours on food intake, but reward eating is present in over half your patients. It's fairly common in the US population. And I think it was mentioned earlier, you mentioned it. What is the #1 craved food in the United States and Europe? Chocolate, exactly.
Yeah, do you want to make a comment or no? Okay, great.
Quick question for Dr. Morgan, but all the rest of the clinic. You have recidivism and trying to maintain abstinence. Some of my patients won't go to see the counselor. Is it appropriate to hand out a vitamin like naltrexone or baclofen in your clinic to help maintain abstinence? And I don't think we do it enough in our clinics in GI.
So where should you look? Do I use it? No. Do I feel bad that I'm not using it in my clinic? Yes. Are there people out there that have set up their hepatology clinics to bring in substance use, naltrexone, things like that? At Campus say yes, and I think it's the right place to do it. Many of these people are not going to go to see substance use. Just so that everybody knows, there's online AA free, and you can have your patients do it anonymously online. So that's another option.
All right, I think we're finished with this session. I want to thank all the speakers and all the people on the panel. And